Good morning and welcome to the 5th Annual Heart Team Conference, Hong Kong Valve 2021. This year, our conference is run in a hybrid format, and we welcome all of you here with us at the venue and those of you over on the web platform. Over the course of these 2 days, we have an exciting program of lectures, recorded cases, and interactive discussions with our renowned experts locally and internationally. May I now invite Professor Hong Fa Che, Chair Professor of Cardiovascular Medicine, University of Hong Kong, and Chief of Cardiology Division, Queen Mary Hospital, to give our opening speech. Professor Zhai, please.
Dear colleagues, friends, welcome you to the Hong Kong Valve 2021. On behalf of the organizing committee of the Heart Team of Queen Mary Hospital, including our team, and also the colleagues from the Department of Cardiothoracic Surgery, I sincerely welcome you to this meeting. The meeting was established in 2017, and this is the 5th anniversary of this scientific meeting. I'm pleased to inform you that actually we start from a very small meeting, now grow to a very international meeting with almost up to 950 participants, and including experts from more than 50 faculty from all over the world, including United States, Hong Kong, Asia, and Europe. And in today's coming 2 days lecture, will feature almost 20 more talks and also 10 cases of presentation. And hope you will be able to enjoy this meeting, and sincerely hope you then have a very fruitful meeting and also keep safe, and hopefully we can join to meet you face to face in the coming year. Thank you.
Good morning. I'm Dr. Catherine Shea from Queen Mary Hospital, and I'll be the session facilitator for this morning. We will now start our morning session focused on aortic valve. So it is my pleasure to introduce our expert panelists for this session. So first, we have Dr. Do-Yeon Kang from South Korea. Dr. Kang is an assistant professor of interventional cardiology at Asan Medical Center, University of Ulsan College of Medicine, Seoul, South Korea. Dr. Kang's area of clinical expertise is complex PCI, coronary imaging and physiology, and transcatheter valve interventions. We also have Dr. Gerald Young from Australia, who is a good friend of ours. Dr. Young is a consultant interventional cardiologist at Fiona Stanley Hospital, Royal Perth Hospital, and Mount Hospital, Australia. He is the head of the structural heart intervention and the interventional head of the high-risk aortic stenosis and TAVI program at Fiona Stanley Hospital. His expertise is in structural heart interventions and has been involved in numerous national and international research studies. Locally, we have our experts, Dr. Kam Tim Chan, consultant cardiologist from Queen Elizabeth Hospital, Dr. Ken Lam Choi, consultant cardiologist from Palmer-Yonge Nethersoul Hospital, Dr. Vincent Kwok, consultant cardiologist from Hong Kong Sanatorium Hospital, and Dr. Eric Chan, associate consultant cardiologist from Queen Mary Hospital. I would like to first introduce our 3 speakers for this session. Firstly, we have Professor Jen Yi from Canada, who will be talking to us about TAVI for pure aortic regurgitation. Professor Yi is a clinical professor and cardiac surgeon at St. Paul's Hospital and Vancouver General Hospital, Canada. He is also the director of clinical cardiac surgery research at the University of British Columbia. He is the pioneer in the development and clinical application of transcatheter heart valve therapies, including TAVI, transcatheter mitral valve replacement or repair, and transcatheter tricuspid therapies. We also have the pleasure to invite Dr. Alan Young from the United States, who will be talking to us about alternative access for TAVI. Professor Young is currently the Li Ka-shing Professor of Cardiology at Stanford University and the Medical Director of Cardiovascular Health, Stanford Medicine, US. His current research interests include non-invasive imaging of assessing vascular function and novel technologies to treat atherosclerosis. Most recently, he has also been leading several major trials of percutaneous interventions at Stanford, and he sits on the editorial board of several major cardiovascular journals. And lastly, we have Professor William Furon from the United States, who will be talking to us about the role of coronary physiology in patients with aortic stenosis. Professor Furan is a professor of cardiovascular medicine at Stanford University, the director of interventional cardiology at Stanford University School of Medicine, and chief of cardiology at the VA Palo Alto healthcare system in the United States. His primary research area is in coronary physiology, and he has been the principal investigator of numerous multi-center trials, including the FAME trials. He has over 250 publications and serves on the editorial board of major cardiovascular journals. So may I now pass on to Professor Yi for the beginning of the first session, and it is always a pleasure to have you here with us. Professor Yi, please.
Good morning, panelists and ladies and gentlemen. First, I'd like to say thanks to Dr. Sui, Dr. Lam, and Dr. Chan for the invitation. And it is my honor to be involved in the Hong Kong Valve again this year. So today I'm going to give a lecture on TAVI for pure aortic regurgitation from transapical to transfemoral approach. So I give a little bit of overview on TAVI for pure aortic regurgitation, and then we'll be show a few cases with TF valve. So this is my disclosure. So as you know, aortic stenosis is quite common and increase with age. Most people think that aortic regurgitation are quite real, and most happened in the young patient. But based on the Framingham heart study, the actual aortic regurgitation also increase with age. If in patient with over 70 years old, the prevalence of aortic regurgitation is over 2%. So as you know, TAVI is already become a standard treatment for aortic stenosis. However, TAVI is not part of the management for pure aortic regurgitation, even in the 2020 ACC and AHA guidelines. The reason is the most commercialized transcatheter valves are designed for aortic stenosis requiring calcification or rigid ring, such as surgical valve for anchoring. In a patient with pure aortic regurgitation without calcification, the problem with off-label THVs is the stability of transcatheter valve. So quite frequently resulting in either migration or require second transcatheter valve for stabilization. Due to this issue, so even with the new generation of THVs, the result is still not really acceptable. Quite frequent, about 10 to 13% may need a second valve for stabilization of the first transcatheter valve. And also there's a relatively high risk of moderate to severe aortic regurgitation. And particularly in the AR patient with off-label transcatheter valve, frequently require pacemaker implantation. This is because usually with off-label transcatheter valve need significant oversizing. And also the implant that most time more towards in the LVOT. That's why it require a high rate of conductive system problems. So I think at this moment, TAVI with off-label TAVI, I don't think it should be used in the majority of AI patient, particular patients that are suitable for aortic valve surgery. I think it probably is not so ethical to use the TAVI with the off-label transcatheter valve for the patient who are suitable for surgery. So the several transcatheter valves with a clipping device that has been confirmed to be effective for both aortic stenosis and aortic regurgitation. I listed here the four devices the Medtronic Engage, that's already off the market for years ago. And the second one is the HeloDoc. That's the Edward device specifically developed for aortic regurgitation. But this device also is not available several years ago. The current available THV with clipping device is a JenaValve and a J-valve. So I have experience with 3 devices. The first device I used for aortic regurgitation is quite early in 2011 or 2012 with Edward HeloDoc and the Sapien XT device. This device basically consists of a dock system. You can see it on left side up. This is a docking system placed outside the aortic leaflets, and the Sapien valve, any balloon expanded valve implanted into inside of the aortic valve, so sandwiching the native aortic leaflets. So this is the case of I did quite a years ago in 2012. So basically aortic regurgitation, and definitely is too high risk for surgical approach. So this procedure is you implanted a docking system to the sinus position transfemorally, and then you can implant a Sapien valve either transapical to sandwich a native aortic valve between the docking system and the transcaster valve, or use a transfemoral approach to implant the Sapien valve. So this device has been quite successfully, and as a result, as you can see, this is a very stable valve implanting the pure aortic regurgitation, and there's really not much perivalve leak or regurgitation. And as a patient that lived quite a years with a very good outcome. There's a reason this is stopped. I think this was originally thinking the AI patient is not frequently required transcaster approach, and also the procedure, because there's need 2 device delivery system to deploy the docking system and the valve, so a little bit complicated. So that's why this valve was stopped. So next valve I used for aortic regurgitation in the 2014 or 2015 was a transapical JenaValve. This valve is self-expandable, and with anchoring device is a V-shaped device which attached to the valve stent. So the procedure is, generally speaking, is pretty simple. So you basically partially deployed the anchoring system, and then trying to position into the aortic sinus. And after confirm the appropriate position of the anchoring device, and then you deploy the valve. And my experience has been great and quite successful, both aortic stenosis and aortic regurgitation. The JenaValve company now developed a transfemoral system, and this is the valve is very similar to the transapical valve with a V-shaped anchoring device attached to the stent frame. So you can see that the tip of the anchoring device is wrapped with some like a soft material. This is basically to prevent the perforation of the aortic valve. So with the pre-shaded introduced sheaths, then you can insert the valve into aortic valve pretty easily. And the valve size up to 27. So it's a relatively small size, because most aortic regurgitation usually have a larger aortic annulus requiring larger valve size. So I think up to 27 may not enough valve size to cover all the patient. This system recently just received CE mark approval. So another valve is I have a personal experience, the J-valve system. So initially I used the J-valve TA system for pure aortic regurgitation. As you know, this valve has been confirmed to be effective for both aortic stenosis and aortic regurgitation in China, and approved by Chinese FDA. China FDA in 2017. And since 2017, this valve has been approved by the Health Canada for special access for inpatients who are not suitable for any other commercialized transcatheter valve. So over the past several years, JC Medical company developed a transfemoral system. It's called the vascular TF system. The valve now is, the stent is very similar to the transapical valve, but the leaflets is now become as using bovine pericardial valve rather than porcine aortic valve. And the stent and the anchor device are very similar. And the reverse system is 18 French. And they have a fully, range of valve size from 22 to 34. I think the large size is necessary for treatment of aortic regurgitation. And the reverse system, as you see here, this is 18 French, 98 centimeter, I think is suitable for majority of the patient. And the tip can be flexed up to about a 200 degree. And the control knob basically have two separate control knobs. One is to control the anchor device, and another one is to control the valve. So what's the difference between the GN valve and the J valve? Because both valves have been confirmed be effective for both aortic stenosis and pure aortic regurgitation. As you know, the designs is a major difference is the anchoring device. The J valve anchoring device is a U-shaped or half-circle device, and is not directly attached to the stent. And the EN valve is an anchor device is V-shaped and attached to the stent. So that makes some unique advantage of J valve. So as listed here, the J valve probably has the lowest leaflet height and stent. Therefore, preserve coronary access probably is the best compared to all other valves. And another, as I mentioned, the anchoring device is different between the two valves. One is actually is not, J valve is not directly attached to the stent, and the EN valve attaches stent. So therefore, when you deploy the anchoring device for the J valve, you can fully deploy it. So it's pretty wide and easy to catch the three leaflets at the same time. And for the GN valve, or the EN valve, because the anchoring device attached to the valve stent, so after deployed, it's not fully deployed. So the diameter is relatively small. Particularly for the AI patient, sometimes it can be difficult to capture three cusps at the same time because it's not fully deployed. And the AI patients are usually the valves are quite open widely. So sometimes it can be a little bit difficult to capture three cusps at the same time. So this is different. And J valve is fully open. It's very easy to capture three leaflets. And another thing is because the different shape of the anchoring device, as I said, the EN valve is the V-shaped, and the J valve is a half circle and U-shaped. So as you see, the aortic cusp also a sort of U-shape or the half circle shape. So this is a J valve. When you're pulling down, this will be automatically achieve true anatomic implantation, particularly in AI patients without calcification. The EN valve can be achieved anatomical implantation, but sometimes it can be shifted a little bit because of the shape of the anchoring device. So they can point to the middle or prevent shift to the side. So the study showed that some percent of patients that may not truly achieve truly anatomical implantation. So that's quite a difference between the two valves. So because of the J valve has the lowest stent and the leaflet's height and achieve true anatomic implantation. So my personal experience, I think theoretically, the J valve can provide the best preservation of coronary access, even in the patient with very low coronary ostium, such as this patient. After implantation, you still have a good coronary access after TAVI. So this is I think is a very unique feature or advantage of the J-valve system. And I have been using the J-valve valve for all the patients who has a high risk of coronary obstruction and has been really successful. So because of the clipping device system, so when you do the valving valve or the aortic native valve, when you implanted the native aortic valve or the surgical valve will be retracted towards the middle of the aorta, rather than if you use the other transcaval valve without the clipping device, they push the leaflets out, so therefore potentially cause a coronary obstruction. Such as this case, as you see here, this case was failed Edward valve, and the CT shows there's a risk for left coronary obstruction. So initially we tried to perform a basilar procedure and then followed by the valving valve with sapien valve. However, this spent a long time. The basilar procedure was failed, and then we performed the valving valve with J valve. As you see here, I implanted J valve, and the left remains here. And even it's safe to do the surgical valve crack. So I use true valve to crack the surgical valve, and it's still, as you see the crack here, and then the coronary artery is still well protected. As you see here, actually it's even wider. So you have really good access to the coronary artery. So this is a really true advantage of the J valve based on my experience. So this, I think the J valve systems really expanded the indication of TAVI. It's not just for purely aortic stenosis or purely aortic regurgitation, but as I said, any patient with high risk of coronary obstruction, the J valve has a very strong protection for coronary obstruction. Either the native aortic valve following David or bento procedure or filled by prosthesis, and also suitable for the mitral valving valve implantation. And especially if patient have a risk of coronary obstruction with failed aortic surgical aortic valve, if we want to do the crack, I think a J valve is a very good option. So I think that the J valve system is really designed for both AS and AI patient, and also now if with the TF system have multiple access. And the unique advantage is this valve, as sapien valve, can be used for the aortic and mitral valving valve. And the most important is it can prevent the coronary obstruction in patient who has native aortic disease or failed surgical bypass with high risk of coronary obstruction, avoid a complex basilar procedure before TAVI in these patients. Another one is because J valve has the lowest profile, like leaflets and the true anatomic implantation, providing the best preservation of coronary access after TAVI and the valving valve compared to all other, I think, the transcatheter valve. Probably best suitable for patients who require good preservation of coronary access. So I will show a few cases with the TF system. So this is the animation. So basically, as usual, the transfemoral approach, you can use either 18 French sheaths or you can insert the device without the sheaths. So initially, you deploy the anchoring device, and then you get push forward because the device is fully open, so it's very easy to capture the 3 aortic cuspid. And when you push down, this actually the device can automatically rotate it. And then after you confirm, of course, you deploy the valve. So this, as you see here, the anchor device will be deployed, and then with your push forward, the device will be opened fully, and then you basically capture all 3 leaflets and place the anchoring device into the 3 sinus. After confirm the good position of the anchoring, and then you can deploy the valve. And during the procedure is usually hemodynamic, very stable in AI patient, and no rapid ventricular pacing is required. So you have a lot of time to think about it, and because the anchoring device once into the sinus are very stable, and you can think about it, you can adjust the final adjustment. So there's lots of time for you to do it. So this is a first in man TFG valve implantation for pure aortic regurgitation. So this is the patient, there's an older patient with severe AI. Of course, is a too high risk for the open heart surgery. And I just show you, quickly show you the videos. So this is the first case, transfemoral. As usual, we inserted 18 flange sheaths transfemorally percutaneously, and then you advance the reverse system through the sheaths to the, they're very easy across the aortic arch, and then to the above the aortic valve. And you can adjust the flexor if you need it, depend on the angle of the ascending aorta. And once you make sure that the anchoring is above the aortic leaflets, and then you deploy the anchoring device. And the next maneuver is because the anchor device and the suture, they have a suture to connect it. So you make sure that the suture is properly positioned. So that's why I'm doing this maneuver to make sure that the suture between the anchoring and anchor device and the stent is well positioned. So they confirmed on the fluoroscopy. And after this confirmed, and then basically try and push the device forward, advance the device into the aortic sinus. And the anchoring device now is placed outside the aortic cuspus in the sinus. So and then you do a fine adjustment of the valve and the anchoring knob to determine what's the best position of the valve. So after confirmed that the anchor device in the bottom of the sinus and the valve is in a good position, a patient usually are very stable. You can have a lot of time to do a fine adjustment. No rush needed. So I just doing the very fine adjustment between the 2 knobs, basically the valve knob and the anchoring knob. So to determine what's the optimal position of the valve for deployment. See, the hemodynamic very stable. We can discuss and achieve consensus. So after you confirm the position of the anchoring device and the valve is appropriate, and then I deploy the valve. Basically, just turn the knob. And after deploying it, and then you try and turn the anchoring device knob to release the three pins that connect to the anchoring device. So after the confirm the 3 pins released from the anchoring device, this delivery system is now free from the J valve. So after this, and we recap the nose cone and trying to retrieve the device. So because it's the first case, so we are very careful. We don't want to the nose cone anything captures the valve and pull the valve back. So that's why we spend quite a bit of time to make sure this device can be, safely withdrawn. But of course, for during the first case, we always trying to be very careful. But actually, there's generally speaking, it's pretty easy to remove the delivery system. So we're trying to adjust the guide wire, trying to bring the nose cone more like in the middle of the valve. So in this time, we feel like this is not completely free from the stent. So we advanced the valve delivery system a little bit just to make sure the nose cone is not capturing anything. But the nose cone is already closed, so it shouldn't be problem with capture the cut on the valve stent. So you can see that the resistant nozzle withdraw from the valve, and then you basically pour it back into the descending aorta. So the valve on the echo, you can see they're well positioned and very stable. And then I can show you the final result. This is the aortogram on the right side. You can see the valve really very well positioned, and the coronary artery actually far away from the valve. There's a very good access to the coronary, no issue. And the echo shows a very minimal or the trivial paravalve leak, almost no leak. So this is a system that we also use for subcranial approach in patients who are femoral artery is not large enough for 18 French, or the ascending aorta is very horizontal. So the subclavian is a very good approach for this kind of situation. As you see, this valve is same. You through the left side is a nicely inserted the system. Either use 18 French sheaths or without the sheaths. Both is fine. And the same procedure is very similar to the transfemoral approach. And you see this aorta is quite horizontal, but with the subclavian approach without any difficulty in the position of the anchor device and the valve, as you see here. And echo shows a great result. So my perspective is with the development of TF systems and dedicated transcatheter valve, I think TAVI will become a standard treatment for pure aortic regurgitation in the near future, particularly in the patient who are high risk for the patient or even moderate risk for surgery. So I think that in the future guidelines, the TAVI probably will be listed as a part of the management for pure aortic regurgitation. Thanks. Stop sharing. Should I stop sharing? Okay, I stop sharing. Okay.
Thank you for that excellent presentation, Professor Yi. So we'll start off with the panelists for any discussion.
This is Alan. So again, very, very impressive procedures. So do you see this as sort of a lot of echo? do you see this valve being sort of a workhorse valve for aortic stenosis as well, sort of competing or sharing the S3 evolute for all sorts of patients, or do you see it as special role for patients with both combined AS and AI, or how do you see it as rather than just a pure AI play, also in AS patient?
Excellent question, Aaron. Nice to see you on. Thank you. So yes, excellent question. I think that I always say in the future I probably need 3 valves. One is a blow expander valve, such as sapien valve. Another valve is a self-expander valve, such as evolute blow or whatever. And another valve probably with transcaval valve is a clipper device, such as J valve. Because if you have each center have a 3 valve, I think you basically can do the TAVI for I think almost all the patients. And the J valve, the position of the J valve or Yen valve, I think it's really you're not compete with other like evolute flow or the sapien 3 valve in AS patient. I think about it, there's a unique advantage for the patient with aortic stenosis or even failed by prosthesis with the coronary obstruction. And these valves are very effective in preventing the coronary obstruction. Another field, of course, is aortic regurgitation, particularly for pure aortic regurgitation. In my personal experience, the J valve probably is the best valve, is easy procedure for the pure aortic regurgitation for sure, because it's an anchoring device, is a half shape, half circle or U-shaped. So it's very easy to position, very easy to capture the leaflets, and I think it's a very unique feature of the J valve. So I say to answer your question, I think it's not a competitor for other valve for AS patients, but for the unique feature for patients who are not suitable for other sapien 3 or the co-valve and the pure AR patient.
Professor Yi, would there be any problem with when you were using the J valve in bicuspid aortic valve?
Excellent question. So yes, most people, I think theoretically, yes, because the anchoring the 3 component or 3 half circle for the unit valve and 3 filler. So we always think yes, will be issue for the bicuspid valve, but actually it's not really a problem, because even the one filler or the one anchoring circle is not capturing the cuspid. There's no problem for stabilize the valve. So most times they will, for the bicuspid valve, usually one cuspid is larger than another one. So at the end of the basic 2 anchoring, the U-shaped anchoring component will be in the one coronary sinus, or the 2 filler in the one coronary sinus. And then you can implant the valve without any problems. For aortic stenosis, the anchoring device is not really important. So it doesn't really matter you capture the leaflets or not capture leaflets, because it's a sort of the function as the positioning, and also as a co-valve, same as a co-valve. So it doesn't really matter. So I used it for bicuspid aortic stenosis and bicuspid aortic regurgitation.
Yes, Professor Yi, great talks. Most of the latest generation TAVI valve got the dedicated sealing skirt to reduce the paravalvular leak. I don't think that's available in your J valve. So according to your experience, what is the percentage of having a significant PVL after the J valve in the cases of severe pure aortic regurgitations? And how do we deal with that? Any bailout procedures? You use high pressure balloon or valve-in valve? What is your percentage of these sort of incidents in your series? Because you're very experienced in using the J valve. Thank you.
So in terms of, great question. In terms of for the aortic regurgitation patient, whether the sealing skirt is needed or not, I'm not 100% sure because this kind of it's basically they push the aortic valve, native aortic valve towards the stent. So that's also acting as this probably sealing skirt. So I'm not sure is the sealing skirt definitely needed for aortic regurgitation. I'm not 100% sure because the three claps basically push all the sleeve towards the J-valve stent.
So what is the incidence of severe PVR after the J-valve? Moderate to
For the
severe?
aortic regurgitation, it's
PVL?
really small.
Oh.
Very small chance have even wider regurgitation. But for the aortic stenosis, the J-valve the force, radial force is not very strong. So the balloon BF definitely needed. You have to use a balloon to open the aortic stenosis before you insert the J-valve. And if really calcified or asymmetric, yes, the valve leak may happen. But sometimes you have to use the post-implantation TAVI with dilatation.
Thank you.
Thank you. I saw that Dr. Kang has a question. Dr. Du Yun?
Professor E, thank you for sharing your excellent case and opinion. And I also agree that the J-valve will be a new hope for the patient with severe AR in high risk. But my concern is that the many AR patients have a concomitant aortic dilatation, and when you treat the AR patient, how do you set the criteria for the transcatheter valve or surgery in the aortic valve dilation patient?
I think excellent questions. So I think at this point, the TAVI with the eyes dedicated to transcatheter valve, I think it's still used for the high-risk patient or a moderate-risk patient for some particular reason is make surgical difficulty. So if patient has aortic regurgitation, if aortic loop is less than 45 millimeter, and they are high risk for surgery, I think the TAVI with J-valve is very reasonable. But if the aortic loop is more than 45 or even 50 millimeter, in this kind of situation, particularly they are not too high risk for the surgery, I will still recommend it for surgery with the loop procedure. Until this durability, long-term or mid-term or long-term durability established. So I think we still need a precaution. But I think the transcatheter valve is a clipping device probably better than better than non-expandable, self-expandable, because your other valve is actually you need a significant oversize. You push the annulus more, outwards. But with a clipping device, actually you're pulling into the middle. So probably has some way to prevent further dilatation. But of course, this is just theory. It is not really confirmed as close follow-up will be necessary. Thanks.
Thank you.
Jen, this is Gerald Young from Australia. Good to see you again. That's a very impressive valve, and I think a couple of your slides you've actually overcome a lot of the problems that the current generation faces, such as critical coronary occlusion. What do you see as the limitation for the J valve? I mean, so far you can take quite a complete picture.
So the excellent questions. The limitation, as I said, the JAVA standard is not like a radio force, not very strong. So for the aortic stenosis, and you definitely need BAV before the implantation. And you usually need, sometimes you need it twice. So you use a large balloon to open the aortic valve, a stenotic valve before the implant valve. Otherwise, it will be a little trouble to withdraw the nose pump because they cannot fully open, and also require the post-implantation balloon dilatation. So I think that that's the downside, and I would suggest don't use this kind of valve if a patient has very strong, like a really heavy calcification, particularly is not symmetric. In this kind of situation, you may have more pelvic leak because the radial force is not very strong, and the valve may be not very circular. So in this kind of patient, I would say, better to use other valves.
Hi, this is Bill Fearon. I thank you for that talk. That was really informative. I wondered if you could expand a little bit about how easy it is to line up the commissures. For example, does it just happen naturally, and how often do you have to readjust? And do you use transesophageal echo mainly to guide that adjustment?
Good question. So usually for the because it's when you deploy the anchoring device, the system is actually quite soft. So with the pushing, because the anchor is half circular, it can be automatically adjusted the position into the sinus. So it's pretty easy to do that. But if you really have an issue, you can just push it up and rotate it a little bit. And for the transacral, you just pull it down, and for the transfemoral, you just push down. So it's pretty easy to achieve this kind of anatomical position because it's the shape of the anchoring device. With the end valve, because it's a shape as a V shape, so sometimes it can be anchoring. It's not self-rotated because you can just push down and not in the middle of the cusp. It could be a little shift to the more commissure. So that's a possibility. I think that's why I make the J valve the easy positioning of the anchor device, particularly in the AI patient. But in the aortic valve, that's not the case because of the calcification.
Thank you, Professor Yi, for your excellent presentation. And I think we all learned a lot. It's interesting and very exciting to see the development of structural heart interventions over all these years, from its use in aortic stenosis, and now with expanded indications, and now we're moving to aortic regurgitation. And this is definitely an exciting field ahead of us. So thank you very much for your presentation and the discussion from our panelists. We would like to move on to the next presentation from Professor Alan Young from the United States and Stanford University. He will be talking to us about alternative access for TAVI. So as TAVI technology continues to advance, there is a continuous need for thinking of alternative access due to the limitations of the need for use of large bore access. And this is a problem in a lot of our patients with comorbidities, including peripheral vascular disease. And so, Professor Young, please proceed with your presentation. Thank you very much.
Thank you very much. I'd like to thank the co-chairman for inviting me to Hong Kong Valve. And I'd like to say hello specifically to Eric Chen, who was here as staff helping us with developing many of the TAVR workflow and also taking care of many of these patients. So thank you, Eric. So alternative access for TAVR obviously is pretty much way in the beginning of our development of TAVR procedures. As you can see here, in the sort of the early days, when we have the XT valves, fair number of patients, up to 20% of the patients, have alternative access beyond transfemoral, because obviously the bore size, the catheter bulkiness requires, for example, direct aortic or transapical approach. But as the device improves in terms of caliber size, as well as the slimness of the S3, you can see that the percentage of non-TF access has shrunk down to approximately 5% in the sort of not even the latest data. Another interesting observation is that, you know, in the United States, there's about 555 hospitals that are doing TAVR, and the median volumes in the TVT registry is approximately 54 cases per year per hospital. And a quarter of these hospitals do less than 36 cases a year. If you look at the operator standpoint, an average is about 27 cases per year, and a quarter of the operators do less than 17 cases a year. So meaning, you know, less than almost just a case a month. But this is the overall TAVR volume. But if you look at non-femoral median volumes, we are talking about, in general, about less than 6% of these volumes are non-TF, and therefore translate to 3 per year for of these average hospitals. And certainly from an operator standpoint, less than 2 cases on average, 1.5 cases per year. So clearly that the non-TF approach is, the volumes are relatively small, and a lot of hospitals and a lot of operators would not have the experience to really be able to perform many of these more complicated cases, especially non-TF is multiple approaches, as I will show you. Also from the TVT registry, another interesting observation is the volume versus mortality relationship. If you look on the left side, these are femoral TAVR, and if you look at the red lines, these are unadjusted 30-day mortality plotted on the annualized hospital procedure volume. So you see the curve is pretty flat, especially if after adjustment of other comorbidities in blue, that once you hit a certain number of volume, from the hospital standpoint, there's not a whole lot of change in terms of mortality. Maybe except in the very low volume side, there's some spread. Obviously, data there is a little weak because of the number of cases per hospital is small. But if you look at the non-femoral TAVR data on the right, you can see that there's a lot of sort of differences as the volume of the non-TAVR cases go down. So you can see whether it's adjusted or non-adjusted, the mortality goes up by almost double in many of these low volume hospitals that try to do non-femoral TAVR. So clearly the message here is that non-femoral TAVR, you need some volumes to really support the ability to do these patients safely, especially many of these patients are higher risk and have more comorbidities as well. So what are the non-femoral vascular access options for TAVR? So here, this picture outlines all the options. From the left side, you can have carotid, you can have direct aortic approach, you can have transeptal approach, the original Alan Cribier's approach. And then you can have transcaval, crossing from vein to artery. You can have a very high sort of approach in the iliac abdominal aorta approach with the chimney graft, for example. And some folks have obviously tried direct descending thoracic aorta approach as well. Or the old days of transapical approach, as well obviously subclavian or axillary approach. Because of some of these, because these are clearly now have fallen out of favor because of the difficulty as well as the associated morbidity and mortality. So these crossed out ones are really now not felt to be of modern use. For example, transapical, given the amount of bleeding, given the amount of complication, really is fallen out of favor. Even the direct aortic is a bit invasive, if you may. So it's kind of been taken over by some centers using a suprasternal approach, essentially using the innominate artery as a substitute for the aorta, and has an advantage because the distance is a little further from the valve, therefore allow you to sort of gain access without have the whole system outside. So let's talk about a few of these and see what are some of the observations from various centers. The carotid, for example. So this is some data that pulled from one center, which is helpful to illustrate the trends. So this is from the St. Luke's American Heart Institute in terms of looking at their volumes of cases or what time of approach they use. So here, transapical versus direct aortic versus transcarotid access from 2012 to 2019. So in the early days, clearly transapical was an alternative use, and over time, clearly because of complication and difficulty, direct aortic becomes sort of the next wave. And finally, if you look at it, the transcarotid approach has pretty much taken over, obviously in the beginning, a few more cases, and then subsequently tapered it down. So pretty much for example, in the Mid-America, the transcarotid will be the first choice as an alternative to transfemoral. So what kind of data do we have? Obviously, there's really no randomized controlled trials. These are collection of experiences, if you may. So here, for example, showing you that the median STS score is pretty high, self-selected out to have an alternative access. The right side slightly more than the left carotid. And you can see that a majority are the sapien valve. So the in-hospital mortality is 2.4%. You can say, well, it's pretty high, but if you adjust it to TBT mortality ratio, it's 0.3, or adjusted to the STS O&E mortality ratio is 0.4. So that's pretty good and tells you that these patients are generally sicker and more comorbidities. And basically, obviously, in-hospital mortality is about 3.6%, which is related to the STS score. If you look at the 1 and 2 year survival following transcarotid TAVR, again, not randomized, but just sort of experience-wise comparing them, you can see that transcarotid seems to have a better 1 and 2 year outcome in terms of comparing sort of different population, but TA and transaortic. One key finding is that obviously stroke rate is 2.4, seems to be higher than obviously transfemoral. And I think from trials, you can see that, again, not head-to-head comparison, it's indeed higher. And there is obviously a length of stay issue. Generally, these patients have longer stay because there's a cut down to the carotid, and they generally sort of stay around 3 days with a spread about 2 days to 5 days. You might be scared of this, but this is not uncommon in certain part of the United States. That even in some patients that you think, some people can say, well, I can always do femoral. But in some patients, obviously, it's impossible to do femoral because this person has a BMI of 68 and basically, underwent transcarotid TAVR and able to get home pretty quickly. So sometimes there's really no other choice but using alternative access. Another approach, obviously, is axillary approach, and this is something that is pretty similar to when you try to put in an axillary impeller. You just need to know the anatomy, that you need to be lateral to the thoracoacromial artery and medial to the circumflexhumeral or subscapular artery. So make sure that that's a safe place to puncture. And then afterwards is pretty much the usual system. So obviously there's needs for multiple, you may say, why do you need carotid and axillary? Because sometimes axillary subclavian not possible, maybe too small, and the sheath could be occlusive, be a problem, and also could be on the left side, and the lemur is there, and it might compromise the lemur LAD flow. And sometimes the angulation could be quite severe and could be difficult and could cause catastrophic complication by tearing the aorta, for example, in the ascending portion. So something that, is, so axillary and the subclavian is a good alternative, but also has this limitation. And we know that transcarotid probably have a little higher stroke rates. Again, maybe patient-related, maybe procedure-related. So the subclavian axillary have no arch manipulation, generally as much, and obviously no carotid artery manipulation. So these two are sort of complementary in certain ways to sort of, one may be better than the other on a person that could not be done transfemorally. Some centers obviously have different approaches, and suprasternal is another possibility. This is a direct surgical cut down again through a small incision, and it's actually relatively straightforward because there's an area that you can cut into the innominate, and that could actually be used to deliver any valve system. And obviously people have previous bypasses, therefore you don't want to re-enter the sternum, or you have radiation, you don't want to sort of enter the thoracic cavity in some way. Patient can generally and obviously mobilize right away. The limitation is really is a distance, and also the makeup of the patient depends on where their suprasternal notch is, and also what's the distance from the innominate to the aorta, and therefore three-dimensional CT reconstruction, both in a sagittal and coronary approach, will be very helpful to determine if a certain patient can be done in this fashion. So here again, reconstructing it, measuring it, and knowing whether it is possible to do this particular procedure. So imaging is very important. Make sure there's no major tortuosity, and obviously be able to reproduce that during the procedure so that the CT guidance will be very helpful. So here, for example, measuring the direct distance to the innominate artery, 15.4 millimeters, and then you can basically reconstruct and plan out your surgery. This is the Colombian experience, again, single center that has done fair number. Their results are quite good with one death, and obviously many of them are extubated in the OR. So the issue again, the stay is longer. So remember the carotid is on average 3 days. This is more because this is sort of more surgical with the sort of entrance of the sort of chest subclavian to the suprasternal notch area. So 4.2 days. Another approach I think is sort of another very interesting approach for patients that who really have no other choices from the arterial standpoint is obviously the transcaval access. And I think this is a sort of an area that more and more of us are trying to explore for patients who have really no other choice. And obviously you all know how this is done somewhat, because obviously it's crossing from the IVC, finding a calcium-free window to get into the aorta. And then you snare it on the aortic side and push it up to the sort of thoracic aorta, and then obviously change over for rigid guide wires, and then subsequently deliver the sheath and TAVI, and then finally close with the nitinol occluder. The part that is always interesting is always the concern that most of us would think that once you make a hole in the aorta, you bleed to death because you would bled into the retroperitoneal space without any restriction. But clearly, this is important to understand. Obviously, physiology of aortic cable shunts is quite interesting. Intuitively, that's exsanguination, and then obviously patient bleed out and could be obviously impossible to control. But what is true is that the aorta obviously have very high pressure on average, and then the pressure in the retroperitoneal institutional space is actually higher than the cable pressure. So if you have a person with a right heart failure in some other way, you might want to measure that. But here is that as long as your hole in the aorta can directly drain into the venous decompression side, there's really no collection of fluid or blood in the retroperitoneal space. However, if you imagine that you have your catheter in the cava and you pull it out from the aorta, but did not completely pull the catheter into the cava, your catheter is actually blocking the hole in the inferior vena cava. Therefore, now you created a hole in the aorta, but has no place to go but into the retroperitoneal space. So therefore, this is a real no-no in doing transcaval, is that when you want to pull the catheter back from aorta to cava, you have to pull it back completely to make sure that you have a drain that can happen. So this is counterintuitive in a certain way, because we always kind of want to pull it slowly and trying to make sure that we have access in various ways, but this is important to remember. That's just basically what happened, is pull it back, the two holes communicate, and you can actually drain. So obviously there's a wire connecting the two holes, so you can always do rescue type of procedure, and obviously that's the wire that you use to deploy your occluder. I'm not going through the setup and access too much. The reason I showed this slide is that it actually needs quite a bit of equipment, especially on the on the side that is with loops there with piggyback wire converters, so changing a 014 wire to 035 wire. You obviously need tamponade catheter if you need to. You need occluders. You obviously need the Agilis small curve to deliver the occluder in a perpendicular fashion. So this is just showing the crossing system that is really a very elegant way of transitioning from an 014 wire that we use to cross from the cava into the aorta. So this is a starter wire. And then we'll sit inside piggyback wire converter, so you can essentially eventually go to a 035 wire and therefore to a Lunderkus wire. Then after that, it's relatively straightforward. And then after, the difficult part is finally just closing these holes. So how does it compare to other alternative access in terms of outcome? Again, no randomized study, different patient population. Again, so the transcaval one probably even have more vascular path because none of the other alternative arterial access is doable. So here, if the 30-day mortality is higher, stroke rate is higher, even pacemaker is higher, vascular complication, even though it's acceptable, is higher. And therefore, obviously the 1 year and 2 year KM survival is unknown. So how do you look upon these different access in terms of outcome? I think stroke is an important one. So transcarotid in various series about 2%, transcaval is a little higher. You may say, why transcaval is higher? Because you are just crossing over just like a TF, but obviously these patients are much higher vascular path and higher atherosclerotic load, and therefore any crossing anything would probably cause you more likely to embolize. So in those patients would be, would you use a cerebral protection device as well? Transaxillary, because of, again, nature of the disease, have from various studies is about 6% as well. So do we really need alternative access? And I think Bill is on this call and Rahul is going to be joining later, is that our experience is that from a couple of years, about 550 TAVRs, we have not turned down anyone due to access issue, meaning that this is not a selected population, meaning we turn down a lot of patients because we have no access and we don't do them. We actually have no turn down due to access. But a lot of them are actually what we call, really preparing the femoral iliac system. And therefore, 35 or so though have balloon predilatation, have cover stent, and when the calcium is very concentric, we use shockwave recently to really open up those femoral iliac area and then do cover stent to prevent any obviously dissection, or if the dissection prevent any perforation. So really, to that time is really 9 alternative access. Couple of carotids, some axillary, and couple of transcaval, obviously maybe a few more since March. It really shows you that a very well-developed transfemoral approach can actually solve a lot of your problem. You really just need, again, about 6% of those cases, you would need alternative access. But important that your center is able to at least master several of these and other non-TF approach so that you can take care of those patients. So in summary, the final slide, what are the pros and cons for various different approaches? If you start from TF, obviously there's no cut down or surgery, no general anesthesia. And if you make the unit of time as 1, the position of operators are very optimal because this is a cath lab procedure. So it's A, outcome is very good. And generally the cost, including the length of stay, is $1 sign if you may. So there's really a first choice for most patients. The carotid involves cut down and involves general anesthesia. Time will be longer because of the cut down and closing. And the position of the operator is not optimal because they are kind of standing on the side and not usually, depends on which carotid, could be on the wrong side. So it could be awkward. The outcome is not as good and obviously involve more dollar sign because of the need of more staff and the cut down procedure. Axillary similarly doesn't need cut down, but still has a similar requirements on the other part. So they are still number 2 equivalent to carotid. So it depends on the anatomy, depends on the size of the arteries. They could be equivalent as a second alternative. The inanimate, it could be one, but again, surgical cut down, general anesthesia, and the position of the operator is terrible because you're sitting on top of the head and therefore very difficult. So I generally favor that this is actually maybe better off to do transcaval in those situations if that's the only remaining artery that you can do, which is really unusual because usually when you have atherosclerosis, it will involve carotid, axillary, and innominate as well. So finally, cable, obviously no cut down for surgery. You need general anesthesia. Time-wise, it's a little longer than carotid and axillary. The position of the operator is very good because you just operate in the regular positions on the right side of the patient. The outcome is not as good as obviously transfemoral and maybe a little worse than carotid and axillary, but it involves a lot of dollar signs because you have occluders, you have the Agilis catheter, you have many other devices that you need to have that to complete this procedure. So generally, the cost is probably more than several times than TF, and the choice will be number 3. So essentially, our default is TF, and then carotid axillary depends on the size, and then finally transcaval. So thank you very much for your attention.
Thank you, Professor Young, for your excellent presentation and offering your expertise and insights into alternative access for TAVI. And I think it's important that we really do think beyond the transapical, the traditional transapical and transfemoral approaches, as this offers, a way to treat some of our patients. Before we move on to the discussion and hold your questions for now, we will move on to our next talk from Professor William Fearon. So, who better to talk to us about coronary physiology than Professor Fearon? It is a delight to have you here with us, also from Stanford University. As we know, coronary artery disease and aortic stenosis often come in hand, and assessment of coronary hemodynamics in patients with aortic stenosis is often difficult and challenging. So Professor William Fearon is going to talk to us about the role of coronary physiology in patients with aortic stenosis. Professor Fearon, please.
Sorry about that, just unmuting. Thank you for that introduction, and thank you and the organizers of Hong Kong Valve for inviting me. It's a pleasure to be here and an honor. These are my disclosures. What I'd like to do in the next 15 minutes or so is talk about the effects of aortic stenosis on the heart, the potential impact of aortic stenosis on some of the coronary physiology measures that we use, such as fractional flow reserve or FFR, and IFR, one of the non-hyperemic pressure ratios, and then discuss the clinical application of FFR and IFR in patients with aortic stenosis and review some of the trials that have been done comparing them. So to start, in classic aortic stenosis, we have an increase in global LV afterload, and this leads to left ventricular hypertrophy and increased end diastolic pressure. There's a decrease in the myocardial perfusion pressure, which leads to myocardial cell apoptosis and fibrosis. And older age and concomitant hypertension and or coronary disease can exacerbate this situation. Because of the stenotic valve, the elevated LV and diastolic pressure, the LVH, and the adverse remodeling of the microvasculature, the hyperemic flow or peak flow achieved with adenosine may be blunted in patients with severe aortic stenosis. And so this can lead to an overestimation of FFR because of this blunting of hyperemia. At the same time, there are a number of changes in heart rate and blood pressure which can occur around TAVR, for example, which might affect non-hyperemic pressure ratios like IFR. So there are a few studies I'd like to review. This is the oldest one. They included 54 patients with aortic stenosis, and they measured FFR in 133 lesions before and after TAVR. Interestingly, they found no overall change in FFR, which was a little bit surprising given what I just described. However, when they broke the cohort down into those with low FFR, less than 0.80 before TAVR, this group had a significant further decrease in their FFR after TAVR from 0.71 to 0.66, while patients who had patients with an FFR above 0.80 for TAVR, they actually had a slight improvement in their FFR from 0.92 to 0.93. That's shown here with the red lines representing the low values and the blue lines the higher values. Now, it turns out that only 6% of lesions had an FFR above 0.80 before TAVR that went down to below 0.80 after TAVR, suggesting that the FFR value is still fairly reliable in guiding, whether or not a lesion, requires revascularization. So I think the take-home messages from this particular study is that there may be some change in hyperemic flow after TAVR, which results in a lower FFR, especially in the patients with underlying CAD. It's hard to explain this slight increase that they saw in FFR in the non-obstructed vessels. Maybe the epicardial vessel size gets bigger after TAVR, but more likely, I think it may have just been a play of chance. This was a secondary analysis that wasn't pre-specified, and to my knowledge, this hasn't been reproduced yet in any other study. In any case, these changes are very small and mostly irrelevant clinically. Now, there was another interesting study of 40 patients where not only did they look at FFR, but they also measured coronary flow reserve and the index of microcirculatory resistance, or IMR, before and after TAVR. And in this slide, you see that the CFR didn't change, although there is quite a lot of variability with some values increasing and some decreasing, but on average, there was no change. Interestingly, FFR actually increased from before to after TAVR from 0.90 to 0.93, and they saw a slight increase in the microvascular resistance, IMR, although it wasn't significant. So in this study, there was a significant increase in FFR. How do we explain this? I mean, maybe it was due to the increase in microvascular resistance, which doesn't really make sense because, as I described, once you unload the aortic stenosis and the LV, you would expect microvascular resistance to go down. I think more likely this was a spurious finding because in this study, it turned out 60% of the patients were on norepinephrine during, and especially before the procedure. And so I think that may have contributed to some of the changes. There also may have been a play of chance in this study too. These were small numbers. But again, the changes were very small and mostly irrelevant clinically. So now looking at a study where they also measured IFR, and this was 28 patients with severe AS, and they did it before and after TAVR. They looked at resting flow too, as well as IFR, and they found that the resting flow tended to increase, but the hyperemic flow definitely increased significantly, which is kind of what we'd expect as you get better microvascular function after TAVR. And you would also expect the microvascular resistance to decrease, which they saw. And so this led to FFR decreasing, again, significantly, but a small amount from 0.87 to 0.85. Interestingly, the IFR didn't change when you looked at the average values. But again, the acute hemodynamic changes from the relief in aortic stenosis appear to affect the FFR measurement and not so much the IFR. Again, these are of unclear significance. Now, in another study that looked at FFR and IFR, they found, again, that the IFR didn't change significantly. However, there were very significant and erratic variations in IFR. And so when you look at the percentage of IFR values that went from above the cutoff of 0.89 to below it, or from below to above, it was 27%. So more than a quarter of cases changed in an important fashion. In the FFR group, only 15% changed, so it appeared to be more reproducible. So although on average, IFR doesn't appear to change much, on the individual patient level, there does seem to be a significant and unpredictable variation from pre to post TAVR. And I think this is related, again, to some of the hemodynamic changes. IFR and the non-hyperemic pressure ratios are more prone to being affected by heart rate change and blood pressure change, whereas FFR, because it's done during hyperemia, is independent to an extent from those changes. Now, a final study that was interesting looked at 96 patients with severe AS, and they compared FFR and IFR to nuclear perfusion scanning. And this first slide looks at the hemodynamic changes after IV adenosine, and I think it addresses one important question is, well, how safe is it to use IV adenosine in your aortic stenosis patients? And this was about 95 patients, and they didn't have any complications. I still think most people, if they're going to measure FFR, tend to use intracoronary adenosine, at least in the United States, just because it has a shorter half-life and doesn't have as much hemodynamic effect, which still, I think, concerns people. But this study did suggest that it's safe to do IV adenosine with aortic stenosis. When you look at a comparison or correlation of FFR and IFR, there is a reasonably good correlation in these patients with aortic stenosis, which mirrors the correlation that we see in non-AS patients, so suggesting that there really isn't that much difference. When you look at the accuracy of IFR using nuclear perfusion imaging as a gold standard, now, of course, that may not be the best gold standard, but in this study, they found that the area under the curve was 0.84. And interestingly, the best cutoff value was 0.82, which is lower than the usual cutoff of 0.89. When they looked at FFR in relation to nuclear perfusion imaging, the AUC was a bit higher at 0.93. Again, the cutoff value wasn't the same as in non-AS patients. It was a little bit higher at 0.83, which kind of makes sense because you might expect that you have some false negative FFRs because of some of the issues I mentioned. But again, you have to take this with a grain of salt because it's using non-invasive imaging as a gold standard. So the take-home messages from this study were that IFR and FFR correlate reasonably well. The best cutoff value seems to be a lot lower with IFR, 0.82 versus 0.89, and the best cutoff value for FFR is a bit higher at 0.83. And at least in this study, FFR correlated better with the nuclear scan than IFR. Now, as we all know, there are a number of other newer techniques for assessing coronary physiology besides using wires, one of those being coronary CT angiography and using computer modeling to calculate a FFR CT. And there was a study shown here where they compared wire-based FFR with FFR CT in patients with aortic stenosis. The idea being that, since many of our patients, well, all of our patients in essence are having CTs done prior to their TAVR as part of their workup, perhaps we could also get CT FFR data to help guide us about the need for coronary angiography and revascularization. And as you can see here, there is a correlation between the two. It's not maybe quite as good as we'd like, but reasonably good correlation between the two. Now, another technique that I know many people are familiar with is using the angiogram to estimate the FFR, so-called angiography-derived FFR, and one particular method is QFR. And there was this study of 115 patients measuring QFR and FFR in patients with aortic stenosis, and using FFR as the gold standard, you see that QFR had a good accuracy. The AUC was 0.88, and it was significantly better than using just the diameter stenosis or the angiographic appearance of the lesion. Now, I wanted to just offer a little bit of a clinical perspective and give an outline of kind of how we approach things at Stanford. I think the role of revascularization at the time of TAVR clearly remains controversial, and there are a number of studies going on to look at this. In our practice, if you have an angiographically clearly significant lesion, we generally opt for, revascularization, and certainly if they're going to have TAVR with PCI, and we'll either do it before, the patient even has the TAVR, or at the time of TAVR before we deploy the valve. And I think that's not necessarily because we think it'll make the procedure safer, but I think the feeling is that once you have put the valve in, sometimes it can be challenging to reaccess the coronaries. And in general, it's a little bit easier just to take care of it ahead of time. And the risk of getting into trouble with severe AS has gotten lower and lower, I think, as our experience has grown. Now, this approach might change if it's a left main, and if you have severe LV dysfunction and severe AS, you might just take care of the valve first and then do the coronary. But in any case, our general approach is, if it's clearly significant, to go ahead and take care of it first. Now, ironically, if your patients have moderate lesions, I don't tend to measure FFR or IFR that often. And the reason is that I think in most of these patients, the aortic stenosis is the main issue. And if we can take care of the aortic stenosis, generally they become asymptomatic and their coronary disease can be managed medically, particularly in a lot of these older patients that we're treating. I think the approach is a little different if you have a young patient. But in any case, in many of these lesions, I think we can defer assessment and just treat the valve, and then reassess them non-invasively, whether just looking at symptoms or stress imaging after TAVR as necessary. So in conclusion, with respect to coronary physiology and aortic stenosis, there are a number of acute changes that occur in coronary hemodynamics and LV function, which affect FFR and IFR measurement in patients with severe AS. The change, at least in the acute setting, appears to be small, although, of course, we don't have a lot of data with longer-term follow-up where there may be even more of a change in the remodeling of the ventricle. And the clinical relevance of these acute changes seems to be small, but remains to be determined. Thank you for your attention.
Thank you, Professor Fearon, for your excellent presentation offering insights into the coronary physiology in patients with aortic stenosis. So now we'll open our panel discussion for the two topics from Professor Alan Young regarding alternative access, and also from Professor Fearon regarding coronary hemodynamics. So for those of you on our web platform, if you have questions, please also enter them into our web platform, and we will answer them and pass it on to our panelists and our speakers.
Could I ask the first question to Dr. Fearon? Thank you for excellent review on this topic. Could I clarify, in all those studies that assessed pre and post TAVI, FFR, or IFR, in all those studies, are they all doing the post TAVI on table immediately after TAVI? And if that is the case, is there any study that assess if there is any further change in the FFR, IFR in a more chronic phase after TAVI? Because we understand that all the hemodynamic, the epicardial flow, or even the microvascular resistance may not immediately go into the chronic phase immediately after TAVI. So is there any data on that, and either FFR, IFR study or other stress test study?
Yeah, that's an excellent question. And I think you're getting at a good point, because there are acute changes that occur that would, could lead to the change in FFR, like I mentioned. But over the longer term, for example, 6 months time or so, I think that there are probably more chronic changes that occur with continued improvement in microvascular function, resolution of left ventricular hypertrophy. And so one could envision that the FFR could go even lower. So I'm not aware of any long-term data. In all of these studies, the measurement was done immediately after TAVR. And I think that another important thing or to acknowledge is that some of the hemodynamic changes, for example, that affect IFR and make the changes acutely that we saw, they may not be as relevant in the long-term setting. So for example, if you did IFR before TAVR and then did your TAVR and then maybe 6 months later repeated it, the IFR may be more reproducible because you have two more stable settings than acutely after TAVR. But again, that has to be shown. To my knowledge, that hasn't been done yet.
Yeah. Well, can I ask a question to Professor Yeung? Yes, Alan, thank you very much for your good talk. Well, I fully agree with you that you mentioned in your first few slides that the use of alternative access nowadays is very difficult for us to acquire the expertise, and you know these cases are more complex and higher complication rate. So my question is that, as you mentioned, that you know nowadays with all these intravascular lithotripsy for the peripheral vessels, downsizing of all the equipment, do you think it's a more practical approach for us, for ordinary TAVI center, to try the transfemoral route first, or even though it's very difficult femoral access, we can try all these intravascular lithotripsy, balloon, etc., to fix the femoral, and then still try the transfemoral route first before considering all these more complex alternative access? Well, do you think it's a more logical approach? The second question is that, as you mentioned, that fully concur with you that should we do this in our ordinary TAVI service center, or should we refer it to a very dedicated center for alternative access before we embark on this more difficult approach? Thank you.
Thank you very much. I think definitely should go ahead and plan for a transfemoral approach first, if it is doable, right? Obviously, if it's occluded, if it is really, impossible, that's a different story. But anything that is on a borderline case, especially the vessel can be dilated, can be stented, and allow you to put a sheath in, so at least you can get to that stage without sacrificing a valve, for example. So you could really test the system, if you may, to see whether that is doable. So from a lot of CT information, talking to vascular surgeon, and plan the case ahead, then I think a lot of the cases that are borderline could be done. The absolutely impossible case, like with really sort of occluded, bilateral femoral iliac system with a fem-fem bypass, for example, then obviously there's no choice. I think it's important in Hong Kong that you should be concentrating the alternative access of certain kinds in one center, because it really allows you to take care of the patients. And I think at that point, obviously, both teams can scrub in if you are indeed referring back to, say, QM or QE, that that you have teams to do it together and gain experience together, but not trying to do it by yourself. I think that's really important. And also pick what are the alternative access you want to master in. So, for example, if you want to master transaxillary or you want to master carotid, so pick one, and one center could do that, or you can pick another center to be really doing transcaval, and therefore allow you to sort of spread some of the expertise, but at the same time concentrate on expertise on one center or two.
Thank you.
So could I follow on this question, Alan? So you mentioned pick one, but I also saw your series that you have a few non-femoral cases and a few carotid, a few transcaval, and a few axillary. So how do you pick, or should you focus one, or you want to try different ones?
So we have added a new faculty. You'll meet him later, Rahul Sharma, who has a lot of experience in all the alternative access. And also we have another new faculty as well, Gusong Khan, that is concentrating at the VA. So we actually added a lot of young firepower to our old people like me, and maybe I shouldn't call Bill old, that allow us to really broaden up the armamentarium. Because to try to do your own first transcaval without any help I think it's asking for trouble. So we basically imported, if you may, expertise into the system that allow us to do transcarotid, axillary, as well as transcaval. So far so good, and so far all these sort of complicated cases we could get done pretty good, as well as a good outcome. And Bill may want to comment on that.
Thank you, Ellen, for the kind remarks, and good to see you here, Bill, as well. And can I ask you a question? What's your take on the latest activation trial while no PCI is tested for non-inferiority against PCI in angiographically significant lesions prior to TAVR, and the trial actually came out negative with high risk of bleeding for PCI arm. So does that contradict our practice of treating angiographically significant lesions prior to TAVR or at the time of TAVR?
Yeah, that's a great question, Eric. Nice to see you. And I think, well, there's more studies coming, first of all. So the complete TAVR trial is another one similarly designed where patients are actually going to have TAVR first and then have their lesions deferred and either randomized to PCI or to medical therapy. So it's kind of like the ischemia trial in patients with AS who had successful TAVR. And my guess is it's probably not going to show any difference between the two strategies, just like ischemia didn't. And part of the reason why that is, and maybe part of the reason why this other study was negative, is because I think we are always faced with the issue of enrollment bias. And for example, what I would envision in complete TAVR is that there are going to be patients who have like a 90% proximal LAD, and the site is going to decide, we'll just do PCI ahead of time, and then we'll do the TAVR, and we're not going to enroll them. And the patients that get enrolled are going to be people who have, 60, maybe 70% narrowings that, the benefit of revascularization is probably less. And so it's harder to show an overall benefit in the study. So, I think it's a challenging scenario because, yes, you want to follow the data, but I think we also have to pay attention to who's being enrolled in the patients and which patients are being enrolled in the study, and use our clinical judgment as well.
Yes, William. Will low flow, low gradient AS affect our interpretation of FFR or IFR in your clinical setting? What do you think about this?
Yeah, so that's a great question. My sense is that most of the patients with low flow, low gradient, paradoxically severe AS. So I should say I'm referring to the group with preserved EF, but they have a low gradient because their flow across the valve is low, their V1 velocity or outflow velocity is low. In those patients, they usually have very small hyperdynamic and thick ventricles. And so I think many have diastolic dysfunction. And so I do think that those patients also suffer from microvascular dysfunction, even though they may not have as severe a gradient across the valve. So I do think we would see similar findings in that cohort.
Well, yes, Alan. Nowadays we're expanding the TAVI indication to intermediate risk and even lower risk. So do you think the route of implantation, femoral versus non-femoral, should be regarded as one of the important, considering factors in view of the fact that, as you mentioned, there's no RCT data on all these non-femoral routes. So for intermediate risk with not possible femoral route, should we refer these patients to surgical AVR rather than embarking on all of these non-femoral TAVI? What do you think about this?
Yeah, very interesting sort of mixture of risk and also approach, right? So the question is that when we almost now doesn't look at the risk profile by STS because it really doesn't matter. We still call them out because of reporting purposes. So if you take away calculating STS scores, the people that actually probably not a good transfemoral candidate likely would have been traditionally higher STS scores. So If a low-risk person that they have no access, may be possible in Hong Kong because it could be a low-risk person but very small, and their arteries turn out to be very small that you cannot get from femoral. I think that those are unique situations that is interesting to study or observe in the Asian countries. Even though majority of the people, even they are small size, 5 foot or less even, they usually have adequate femoral arteries. So I would say you have to balance everything. So if they are low risk by traditional STS scores, but obviously their access is not possible, most likely it's being small rather than atherosclerotic and so forth. That's, surgery certainly an option, especially they're young, especially there might be a bicuspid features, fused raphe of different kinds. So I don't have a single answer, but I would say that, the alternative access typically goes with higher risk patients because of the various comorbidities associated with it.
Yes, okay, thank you.
Thank you. I think Dr. Kang has a question.
Thanks to Dr. Barron for your excellent lecture. I'm Dr. Kang from Asan Medical Center, and I would share the strategy in Asan Medical Center. Now we are checking both IFR and SFR with IV adenosine in all TAVI patients with coronary disease. And as you mentioned, IV adenosine is safe because we did not experience any significant adverse event or patient adverse event with it. And we are selecting PCI strategy by FFR. And as you mentioned, we also believe that deferring such controversial region would be better. In usual cases, FFR is not significant, it is higher, while IFR is low. So we could defer many patients by FFR guided PCI strategy. The concern of deferral of coronary disease before TAVR is the difficulty of coronary access at the TAVR, especially in younger patients. And do you have any concern or strategy in such a patient with coronary disease with a default coronary artery, selecting TAVI valve or size or selection of valve?
Sorry, I heard most of it, but the last part I broke out a little bit when you said, do we have any selection data on deferring based on FFR or?
Oh yeah, in default patient, coronary access would be a concern during the clinical practice, and then the selection or other strategy of step forward.
Yes, that's a great question. Thank you. And we do definitely pay attention to that. So in our patients where we think there's especially if they're young, like you say, or if they have some moderate disease and there's a higher likelihood of that perhaps progressing and needing re-access to the coronary arteries, in general, we will opt, if there's no reason not to, for the balloon expandable SAPIEN 3, just because that's, in our experience, easier to access the coronaries compared to the Evolut Pro. So yeah, we would pay attention to that for sure. That's a great question.
So I think Dr. Kwok does a lot of high-risk, complex PCI procedures in private practice, as well as on patients with structural heart diseases such as severe aortic stenosis. So Dr. Kwok, what is your take on treating these patients? Will you fix the valvular pathology first, or what is the usual practice? Will you do the PCI first?
Hello?
Yeah. Okay.
So I think it's all depends on the anatomy as well, all right? And every patient is different. So patients with acute coronary syndrome and also concomitant aortic stenosis, then you have to assess both conditions. And as the faculty mentioned, most of the time in elderly patients, the severe aortic stenosis may be the culprit. And it also depends on the patient's presentation. You might have to fix both at the same sitting if the situation allows, all right? And we tend to revascularize before TAVI in the past, but now with all the data growing and the guidelines change, maybe if for moderate lesions, of course, we might need coronary physiology assessment or leave it for medical therapy and fix the valve first.
Thank you.
Okay, thank you for that excellent discussion. So I think we will finish up with this morning session. Thank you to all the speakers, panelists for that very fruitful talk. We are going to have a short break of around 10 minutes, and please come back here at around 11:10 for the second session. Please be reminded for the CME, CNE outside and the booths outside, and we'll join our second session at 11:10. Thank you.
Thank you.
心瓣疾病係可以出現得無聲無息，記得定期做心臟檢查，請教醫生專業意見，及早治療。由今日開始，一齊關注心瓣健康。 心瓣疾病係可以出現得無聲無息，記得定期做心臟檢查，請教醫生專業意見，及早治療。由今日開始，一齊關注心瓣健康。心瓣疾病係可以出現得無聲無息，記得定期做心臟檢查，請教醫生專業意見，及早治療。由今日開始，一齊關注心瓣健康。